all of you for joining us on behalf of Advanced Surgical Skill Enhancement Division, Anepoya, deemed to be university. We are very happy to announce that we are getting a very good encouragement and an appreciation all over from the country that regarding our series Veterinary Talks. And this is one of our good thing that to share with you. This is the 5th veterinary talk that we are doing today. And I would like to thank our Honorable Vice Chancellor, Professor Dr. M. Vijay Kumar sir, for providing us an opportunity and a platform for conducting a series under the name Veterinary Talks for the veterinary professionals. I would also like to thank all of the speakers for volunteering their time with us for the knowledge sharing thing. And with that, before we get started, I would like to inform you all that the webinar is being recorded, and the recording will be made available for the future reference. And this link will be shared with you all through the emails. If you want to get it to the link, then you can also visit our Anepoya YouTube website channel for getting all the recorded videos. And everybody who is in the audience, I kindly request you all for muting your audio as well as video for effective learning experience. By doing so, you need not to get worried for being seen or being heard. And with this, I will get into our today's webinar. Today, we have our special invitee from Colombia, that is Dr. Daniela Martinez Ramirez. She is an expert equine veterinarian. We got her contact through the Instagram profile. Dr. Daniela, she's a graduate of La Salle University, that is located in Colombia. She has her internship in equine sports and internal medicine. She has a good professional background, that is she has a professional interest like equine anesthesiology, equine neonatology, like ozonotherapy. Most of all, we are unaware of that ozonotherapy, and as such equine internal medicine and the sports medicine and many more. We have found many such works of her through the Instagram. She used to put her many videos, and all the case reports she used to share. Those are very amazing to see and to watch. They are very knowledgeous. And with coming to the equine field, that in most of us veterinarians in the India, like many veterinarians, like small animal veterinarians or the farm animal veterinarians, all of us, we used to treat the equines as usual, but comparatively to the ruminants, equines are a bit difficult, we all know. But the treatment wise, a simple treatment wise, giving an injection wise is also very different compared to the ruminants. By keeping in that mind, today we selected Dr. Daniela to explain us what are the do's and don'ts in the equines, basics things from starting from the neonates to the anesthesia. And this is a very good opportunity for us, all of us, to learn, so that we can learn many things with this. And keeping in that mind, I would like to tell all of you that happy learning. And if anyone wants to ask a question while presentation to the speaker, I would encourage you people to put your questions in the chat window. This will be monitored by myself continuously, and I will going to ask the speaker to answer as many questions as possible within the stipulated time period that we have here today. And finally, at the end of the webinars, we is going to have a question and an answer session, where in which I will going to ask, and it will be a very good webinar. With this, I would like to hand over the screen to Dr. Daniela, and happy learning all. Thank you.
Okay, good morning, everybody. Very nice to meet you. Thank you for having me. I'm very happy because this is an opportunity for you to learn what I have been doing in the States and the reality that I'm from a third country as well. So I have like the two sides of the money, you know? So I'm gonna share my screen.
Yes, please.
Can you see it now?
Yes, ma'am. It is presenting.
Okay. So today I'm going to talk about basic equine field medicine, taking in mind that I know the lack of resources in our country is a huge problematic for us to give a good veterinary service. So I just want to clarify that I don't have any financial conflicts of interest to disclose this presentation. Who I am a veterinarian doctor. My degree is from Colombia. Uh, However, I did two externships in Ocala and Kentucky in the United States. I work as an veterinarian in Ocala for 4 years. I focus mostly in internal medicine, anesthesia, and neonatology. And one of my biggest goals during this journey has been focused on client and community education. I know that we want most of the times to provide a good medical service, but if we don't have a good communication with our client and people doesn't understand what we are doing, we're not going to succeed. So the objective for this presentation is to show most common cases and therapeutic approach of the field medicine in workhorses, donkeys, and mules. What happens? I know that in our countries, I guess in India as well and Latin America, horses, donkeys, and mules are sustained for families. So mostly we don't have like sport horses or show horses, but mostly horses that are working for provide feed to families, right? So what happens in Colombia versus what happens in the States, that obviously there are more resources. There is lack of resources. We have biosecurity management. It's very, very poor. And the sanitary guidelines are not as strict as in the States. So vaccination protocols, deworming protocols are not are established as in the States. Then we have deficient client and farm workers education. So what happens in Colombia is that people that are taking care of the horses, they think they are vets. So they are doing stuff that are wrong. And because they have been doing this for a long, long time, it's hard for a young vet to get to know how to approach them and how to tell them that we need to do things different. Usually workers treat the horses until it gets really, really complicated. So when you get to get the horse, it's a really, really bad case to treat. And they need to call a vet. So they start giving phenylbutazone, they start giving Vanamine, they start doing wrong bandages, they start doing wrong therapies. And then when the horse is really complicated, then they call you. So in most cases, you're gonna see really, really complicated horses. So my goals, the first one is to provide the best quality medicine possible in the field. Even if we have lack of resources, there is always ways to do the things in a correct way. Look alternative when there is a lack of resources of materials, and then perform a complete clinical exams. So don't focus if you don't have an X-ray machine or if you don't have an ultrasound available at the moment. But if you have good practice in doing your clinical exam from beginning to end in an order way, that you follow a protocol that is not going to allow you to miss anything in the horse, that is going to give you 50% of your medical approach, okay? The consultarism might not be the only health problem in these horses. So don't focus if you're calling because you have a lame horse. Don't just focus in the biomechanic or the layman's exam. Do the whole physical exam. I have seen this. We don't take temperatures anymore. We don't check the teeth of the horse, so we don't know how that horse is eating. We don't even use the stethoscope to learn to hear the motility of the horse. So all of these aspects we need to take it into account for these work horses. Always communicate in a simple language to the owners and workers. So try not to be very technical at the moment to explain to a horse owner in these cases what do you need to do. Try to use a very, very simple way to communicate your intention. And then again, this is very important for me, focus on client and community education. So the first thing that I do very frequently is field general anesthesia. And I know that we have done this like a recipe for kitchen, and we do everything for the horses at the same time in the same way, and this doesn't work. So always perform before you're gonna put a horse on the under general anesthesia in the field. Perform a complete physical exam. Hear the heart of this horse. Make sure that it's okay. Make sure that you have a good perfusion, and this is things that are really simple to do. So mostly we do castrations in the field, and then the anesthesia protocol can change depending on what you have available. But what I usually do is silacine. I use 1 milligram per kilogram in the horse, depending of the temperament. If you have a horse with a harm or with a hot blood, you might use 1.2, or if you have a very easy horse, you can do 0.8 milligrams per kilogram. Then you're gonna count by clock 5 minutes. Do not rush into take the horse down. Give it the time for the pre-medication to work, because if you rush, the horse is gonna wake up as crazy, and it's gonna be dangerous for you, for the horse, for the people that is helping you around. Okay, so silacine most of the time. If you have available dexmedetomidine, I don't know if that it's available for you guys. In Colombia, it's very expensive. In the States, we usually very frequently. Always combine with an opioid that in most cases is butorphanol. That is very expensive as well, but if you can use it, please do it, because horses have a very induction to the anesthesia, and in the same way, they wake up in a better way, right? So once you have your horse under the silacine effect, what will you see in a horse that is under silacine? The front limbs are gonna be abaxial, then the head is gonna come down, and then you don't have the menace reflex as active as it will be in a normal horse. Then once you have the horse in that state, you can go with the induction. I usually use ketamine, 2.5 milligrams per kilogram, plus diazepam. This works me very nicely, especially in horses that are really difficult, that are aggressive, that are really hot blood. It works because it gives you like potential effects for the drugs to keep working for a longer period of time. So the diazepam, I usually use a dose of 0.06 milligrams per kilogram. Then you have to do this as a bolus very fast, okay? And you have to be ready, because when you give this medication, the horse is gonna come down very fast. So you're gonna have a person in the tail, you're gonna be in the head of the horse, holding the head upwards. Once you put the medication, the horse is gonna start to fall. You're gonna sit it down, the horse, and then the head is gonna be coming slowly to the floor. So how do you know that you're doing a good anesthesia? Is because you're having control over the horse, and the horse is not fighting you, okay? So the horse doesn't have to slap on the floor or start like circling around. You need to sit the horse and then coming slowly and nicely to the floor, right? Once you take the horse down there, always take the halter off. Do not do anesthesia with the halter in, because you can cause paralysis of the radial nerve. Same thing with the leg, sorry, with the facial nerve, with the halter. And then the leg that is gonna be closer to the floor, you're gonna put it up the most that you can, so you don't cause a nerve, radial nerve paralysis, okay?
Yes.
So those are very important things that you need to keep always in mind during the anesthesia, because if you keep a halter and then you have a paralysis, the horse is not going to be able to eat, and you're going to have a trouble in there. Okay, then the maintenance. What I usually do is a triple drop, or in the worst scenario that I don't have all the materials available, I will do a double drop. What is triple drop? Is ketamine, silacine, and a muscle relaxant. I don't know what you have available in your country. Let me check. I wrote. Do you have any question?
No, 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 no. You can
Oh,
continue.
okay. Okay.
These are
So
available. These
what
are
I
available.
mostly
These anesthesias are available here also.
Okay, awesome. So what I usually do in Colombia is white venison. Um, so what it calls triple drop, I use 500 of white venison, they 500 grams of ketamine, and then the same amount of xylazine. If I don't have the white venison available, what it has been happened to me, I only use just saline, regular saline, or you can use LRS, and then xylazine and ketamine. Just keep in mind that if you do this double drug, the horse is gonna wake up with muscle tremors because you don't have the muscle relaxant activity in there, right? I don't know in India, but in Colombia we have this white venison in powder. So I prep it, I put it in the microwave for I will say like 15 minutes and then dilute it in a solution. That works. In the States, you can get it really easy just in a bottle. So depending on what you have available. Okay, what are the most frequently ambulatory surgeries that we perform? Hernias, castrations, I said before, big traumas or surgical that require surgical correction, and then tenotomies of the lateral digital extensor tendon. In the past of horses, we have a pathology that is called stringhold. I don't know if that happens to you guys, but it's mostly an hyperextension of the tarsus. And then we do this tenotomy for release the pressure. It is really controversy because we have a lot of horses that reseed, and then after the surgery they start like doing stranglehold again. So it depends on the case, but we can do it in the field. It's a really short surgery. It's not simple, but it's short. So if we have like everything um, to simulate a surgical suite in the field, we can do it. Then anesthesia in falls. This is a subject that I really love because I have been in every position. So I was a learner first, and then I saw a lot of falls dying because most of these falls are septic. So in Colombia, we have really high indices of neonatal septicemia, um, a lot of dummy falls. We'll have a lot of placentitis. So what happens? We have a fall that is really, really unstable, and most of the cases people want to do the procedures really fast. So what we need to do is to stabilize the horse first before thinking in putting him under general anesthesia, because most of these horses are not gonna support all the procedure. Okay, so because we have usually septic falls, and you know that when we have a septicemia around, the anesthesia doesn't work as well. So you have to plan really well how is going to be your protocol, and you need to perform an internal medicine evaluation of this fall. How old is he? How long has he been having clinical signs? What are your blood work giving you? In these horses, it's really important to do blood work. Usually, I won't say that you need to do pre-surgical blood test before putting a horse under general anesthesia on the field, but for falls, at least do an hemogram, a CBC. If you can do the chemistry, that will be great. If you can't, at least keep your CBC in mind. Okay. I always do mylar catheters, long catheters in these falls. Do not use short catheters because they don't last. And usually after the anesthesia, you will need the person that is in the farm to take care of the horse and to start giving medication through that catheter. Every 6 hours if you do penicillin, every 12 hours if you do amikacin. So always try to keep a long catheter, a mylar catheter, 14 gauge in these falls. You can, these catheters usually are more expensive, but if you think it, if you put a short catheter, it's gonna last one day, and you're gonna start needing like to change it every day. So it's gonna be expensive for you to go to the farm, put a catheter again. Um, restrain the fall, and it's going to be obviously more painful for him. So these catheters, if you take care of them well, they can last up to 3 days. Okay, they have antibiotic in the PRN, so they last like a considerable time of to work with. Do not treat more than 2 joints at the same time in anesthesia. And I'm telling you, unless you have a really big team to help you and to work like synchronized in the procedure, do not try to do more than 2 joints, because the anesthesia time is going to be too long and you can lose the flow. And that had happened to me. So please don't do it. If you need to do 1 day, and then if you have 4 joints infected, I have seen cases with that. Try to do 2 1 day and then 2 the next one. And then you have like a more secure anesthesia period, okay? Mostly I do regional lymph perfusions or joint flush. What I use in falls is xylazine and ketamine. The xylazine I use, I will say 0.08 milligrams per kilogram. The ketamine, 2 milligrams per kilogram. You can go up to 2.5, but I will try not to get to that point because they get really dissociated with the ketamine. Okay. Okay, disadvantages. I would love to use butorphanol. It is a really good helper in getting the recovery better for the horse. It is very, very expensive. It is very expensive in the States as well, but they have the resources to use it, so they use it very often. In Colombia, I try to use it in falls because obviously you need like lower volumes of the medication, so it lasts longer. I won't use it in a big horse because it's gonna be too much and it's gonna be very expensive. The other disadvantage that I have in Colombia is the Pasofino horses. They have a really, really difficult temperament. And I don't know if it's only because of the breed or the way we have been treating these horses for years and years and years. So there are horses that since they are foals, they are getting really aggressive techniques of restraint. For the shows, they do things that are not ethical. So these horses get to be really, really predisposed when someone is going to approach them. And mostly if you're going to do something that is going to be painful and annoying for the horse. Okay. So with these protocols that I just told you, the recovery is not always as smooth as we would like because we don't have the butorphanol. Sometimes we don't have the guaifenesin. So you need to have really trained people to help you out when you have a recovery horse from anesthesia in the field, because if not, you're going to have accidents for the horse, accidents for the people working around you. So make sure that if you're going to do this, just have people that knows what they're doing, and they are going to be able to respond and to react fast if something gets wrong, because when you're working with horses this big, you always have a chance that you're going to have an accident, right? So as I said, guaifenesin is not always available as a injectable solution, at least in Colombia. So this is the homemade preparation. If you want to take a screenshot of it, what we want to do is to get a solution up to the 5% or 10%, depending on what procedure you're going to perform. So what I do is 50 grams in 1 liter of LRS of saline, it really doesn't matter, or you can do the half in 15 mLs, okay? So put it in the microwave, make sure it's really, really wet dilute, that you don't have crystals on it, and then you can use it on the horse. Obviously, you have to wait until it's completely to a regular temperature, okay? Do not use it if it's really hot. Okay, about vaccination protocols. In Colombia, it's pretty simple. We have Venezuelan equine encephalitis, equine influenza, tetanus, and rabies. As I say, there is not as regulation as it is in the States to have your vaccinates update every single year. So once in a while they do it, we don't test. So we have a lot of tetanus cases. This is a really important thing. I guess it happens the same to you, but I've seen in Colombia a lot of tetanus cases with the paralysis, with the neurological signs, and these are horses that are usually not having a good prognosis. Is really hard to take them out from this pathology. In the States, I've never seen a horse with tetanus. Mostly is because they have a really strict protocol with dyspepsia. So every time they're going to perform a procedure, even if it's just a joint injection, they scrub 5 times with chlorhexidine, alcohol. They don't use, and that's something that I adapt to my practice. I know chlorhexidine is expensive than the Jody, but it works better for me. So chlorhexidine 5 times with alcohol, and they have really strict protocols for performing surgical procedures or aseptic procedures, even if it's in the field. They try to keep everything really, really clean. In Colombia, it doesn't work as well. So from castrations, we have a lot of tetanus cases, then castrations that are performed not from vets, just from the people that is working in the farm, and usually they get really, really complicated. Now, what is very common for me is wounds and trauma. So as I said in the beginning, what happens is the horse gets a cut, gets a little tiny lesion. People start doing things, giving an antibiotic if they have something available, giving Banamine or phenylbutazone. And then when they get to this, as you see in the images, then they call you because they couldn't control the infection, because they didn't control the pain, because the joint is infected as well, and it's a mess. So this has a really, really bad prognosis. What can we do if we don't have a lot of resources? Because what happens in the States is that a veterinarian will often offer you, okay, we can do laser therapy, we can do hyperbaric chamber, we can do MagnaWave, we can do therapy with vancomycin, that I don't know if you know, but it's an antibiotic that is very, very expensive. It works well, but it's very expensive and hard to find. Then we have imipenem. But in the reality of our countries, this is not a chance that we can get this horse to a hyperbaric chamber, right? So what would I do? I will really, really pressure the owner to give me the chance to take our X-ray so that I can know how affected is the joint. Because if you see this picture, you are in the tarsus, just in the middle of the joint. So probably that infection has been there for more than 2 weeks, and then you're not fighting a skin issue, you're fighting a joint infection. So first thing, I will try to take a radiograph. If I see that the joint is too infected, I will tell the owner that the probability of this horse to get well is really, really poor. But if they don't allow me to do the X-ray, what would I do is add regional lymph perfusions every single day. You can perform it every 24 hours for 5 days. And then if the horse is getting better, you can take it up to for 48 hours or even up to every 3 days, okay? So the regional perfusion, you will put a tourniquet on the top. Always make sure that if you have close to a soft tissue structure like the suspensory ligament or the suspensory branches, just put gauzes like a sponge between. Do not tourniquet around very tight. Just the necessary pressure to keep the medication going down. And then I will do amikacin as my first option. If this doesn't work, we can use vancomycin, we can use imipenem. I know these are drugs that are really hard to find, that are really expensive. But ideally, in our medical world, I will do culture and antibiogram. Yeah, so you're gonna start, because as I said, usually these horses have been doing antibiotics for a long time because people in the farm will give it to them. So most frequently penicillins, amikacin. So try to do it with amikacin first, then we have opposite. So in Colombia, what we use mostly is sugar. We have brown sugar, and then we have something called panela. That is like the first product before the sugar is processed. So we make it powder, put it in the skin, and then bandage it. One thing, be very careful with bandages, because these people usually bandage the horse in a wrong way, and then you don't have just this injury, you don't have this wound, but you have ligament or tendon injury. Okay, so bandages are always going to go backwards, taking the tendons medially. I don't like to say backwards because if you change your leg, you're gonna get confused. So always take your ligaments medially to the horse. Do not take it outwards, because you're gonna hurt those tissues. Okay, so you bandage the horse, and depending on how long it will last, I will say like 1.5 day, you start changing it. It helps with the healing and with the scar tissue. It doesn't heal as nicely as we would like to, but it heals. You know, it creates a lot of granulation tissue, and somehow it really controls the infection. So that's what I would recommend. You can use honey as well. Just try, if you are in a really hot weather, to bandage it really cool, because if not, you're gonna get a lot of flies, and then you will have abronymiasis that we will see later in this presentation. Okay, large laceration in this type of lesions, try to suture in a really nice continued pattern. Okay, so this is something that you can really approach in the field. You can do a light sedation with xylazine, and then flush before you're gonna close a wound. Flush it really wet with saline. Always, always, always. Try to do it with the venophysis really, really inside the wound. Clean it really well, clip it, take all the hair off, because if the hair goes in the skin, it's gonna create a worse infection. And then you can just suture. Try to suture muscle first. Try to do a subcuticular suture, and then you can close the skin. So if you see this lesion in your right side, is not as pretty as I would like, but it closed. It closed without infection. So that works. I mean, if you don't have a lot of resources and this is not a show horse, it works. So you can do this. I don't know if you have laser therapy available in India. We have some people that do it in Colombia. It's not as expensive as we imagine. So maybe if there is a possibility and the owner have a little bit of money, we can suggest that, because the laser really helps to control the infection and to create scar tissue. Now, abronymiasis is something really common in Colombia, in the States, at least in Florida where I was. It's really common because there is flies all year long. I guess is the same case in India. So what we need to do, and because if you go to a literature, authors really describe too many treatments for abronymiasis. What I will recommend is doing this prevently. So please try to work in fly sprays, making solution to spray the horse all over around, so you don't have a lot of flies around the horse, because a little bit of cut or a little of blood is going to create a mess. Then you can curettage this to take all the eggs out. And it's important to keep the worming with ivermectin in your horses. If you don't worm the horse, it's gonna keep creating a cycle that is never gonna end. Okay. Then we have Somerset mix, that basically it's DMCO. I don't know if you guys have available DMCO in gel, like in a solid presentation. We have it in Colombia solid, like jelly, or we have liquid. If you have the liquid, you can do the same thing. You can use furacin with DMCO. You can use a little bit of aspirin, and you can put ivermectin in powder in the mix. You mix this all, and you can use this solution to cover the lesion, okay? And then obviously do bandages. It is important that you curettage these lesions frequently, because if you don't take the worms out is not gonna heal, okay? Now, Neoburn Falls, and this is something that I really learned from a veterinarian that was in the States but was working in Colombia. We need to start doing preventive medicine in every single falls. So we have farms that every single fall that burns, um, we go there, we take glycemic medicine, and then we take IgG sample for test. You need to know how is the immunity of this fall, because if it's low, you can do something right now. You don't have to wait until the fall gets septic and gets really complicated and have hypopyon and joint infection. So you can give him tools to avoid all these pathologies. Okay. What happens when you have a failure in the passive transfer? That is usually because you have your IgG below 800. You're gonna do, even if the fall looks good, because at the moment it's gonna look good. Even if it looks good without signs of joint infection, without signs of septicemia, please do a plasma transfusion. You don't even need transfusion bags to do this. Okay, so I'm gonna teach you how to do it in a homemade way. Okay, if you don't have transfusion bags available, what you're gonna to do is you can get citrate in powder, the anticoagulant powder. So you're gonna use 24 grams of citrate in powder in 1 liter of saline. Use saline because I have seen, this is not in any book, but I have seen that in LRS, it gets crystals really fast. So try to do it in saline, and then you're gonna prepare the solution, okay? This is gonna be your anticoagulant solution. Then you're gonna put 200 mLs of this solution that you just prepared in an empty little bag. So try when you are in a hospital or when you have a horse that is under hospitalization to keep your empty bags for fluids, because you're gonna use them for this plasma transfusion. Obviously, try to keep them really, really clean, okay? So you're gonna use 200 mLs, and then in this bag, with a 14 gauge catheter, put it in the opposite way. I mean, from down to up, you're gonna collect 8 mLs of whole blood from the mare, okay? You're gonna wait 12 to 24 hours. So you can hold these bags in any part. There is a dark room in the farm, okay? You can put it there, you can wait. If the fall is really, really bad, you can wait just 12 hours. If you can get to wait the whole day, it's better. So you're gonna have the separation between the plasma and the blood, and then you're gonna poke the bag on the top where the plasma is, and you're gonna collect the plasma in a new bag, okay? So this was pretty much that I have all my information for you. If you have any question, please feel free to write it on the chat, or you can contact me via Instagram in Horse Medicine. This is my email address if you have any more questions.
Thank you very much, Dr. Daniela. It was
You're welcome.
great information today. And the NEVA one, the transfusion, the plasma transfusion was just amazing. Many of our audiences will going to try and learn from that one. And I have got many questions right now from the audiences. Some of them I have asked the questions which are already explained by you. That is briefly explained regarding the triple drip anesthesia.
Okay, so for the triple drip, as I said, is you're gonna use 500 grams of xylazine, then same amount for ketamine, and 500 mLs of white phenicin if you have it available. As I said, you can prepare it if you have the white phenicin in powder. This is a possibility, and I have done a lot of time, and it works well. Then the dose that I use is 2 mLs per kilogram per hour. What happens? We have doses, but most of the time we do this depending on the response of the horse. So you have to be very clinical in how you're approaching the horse, because you have a horse that is not intubated. that if it gets one apnea, you don't have a way to assist them because you don't have a ventilator available in the field, right?
Yes.
So your stethoscope, it's important, but I will mostly focus on is the eye reflex. So I have been doing, I'm not saying that you can do this and I don't recommend it, but I have to do an anesthesia without a stethoscope, without hearing the heart. I have no idea if the horse have hair rate or not. But if I have the eye and I can see it and I can see how this reflex is working, I can perform an anesthesia, okay? Also, focus on the laxitude of the mouth. So if you can open the mouth easily, you have a horse in a good plane of anesthesia. If the horse is fighting you to open, then you can tell the surgeon to start doing a castration because the horse is feeling, right? So keep these very important details in mind when you are using triple drop, because if you open the whole flush and you can keep going, you can go too deep, and then it's gonna be hard for you to bring this horse back into recovery. And for sure, the horse is gonna recover in a really bad way, and we can hurt them. So with the triple drop, I have this dose 2 ml per kilogram per hour, but usually try to do it depending on the response to the horse of the anesthesia. Okay. Okay, I'm reading here.
Yeah. The question is the route and the dose. Dr. Ravi Raidurg has asked the question, which is regarding the dose, route, and presentation of antitetanus toxide of the serum.
Okay, so
First of all,
I have bad news for you. And in Colombia, we don't have antitetanus toxin available anymore. So that's why I said that it's really complicated to treat these cases, because usually when we get the horse is because the horse is having seizures and is having neurological signs. So I have seen 5 horses with tetanus. All of them, we have to put them down because we really don't have a way to control that neurological signs. And in the States, I have never seen a case of tetanus. So I'm not sure. I guess they have antitetanus toxin. I guess they have it, but I've never used it because I haven't seen a case with tetanus in the States.
As a prophylactic, how much will you recommend, ma'am? Prophylactic.
For prophylactic, vaccine once a year.
Dose and the route they are asking, the prophylactic.
The prophylactic, though, I wouldn't use antitetanus toxin prophylactically because you can induce like a static contraction of the muscles. And if you have sport horses, obviously you don't want to get muscles disease, right? So I wouldn't use prophylactically. I just will recommend to vaccinate every single year against tetanus.
Thank you. Another question, Dr. Gokul T has asked regarding antibiotics that we can be used for the regional limb perfusion. Most often the regional limb perfusion we do in case of like a foot puncture or foot abscess.
Okay, so what I mostly use for regional limb perfusion is amikacin. I usually use 1 gram. You can dilute it in 20 ml of saline. So never use the antibiotic, any of them, without diluting them, because it's gonna be too harmful for the vessel that you're poking, right? So amikacin is what I usually use. It works for me. In falls, it works really well. If you have resistance to antibiotics, that this happens really common in Colombia and in the States as well, because as I said, the farmers are giving these horses antibiotics the next day they were born. So we have a lot of resistance. I will recommend not to try like very different antibiotics, but if you have to invest in something, just do a culture, an antibiogram, and then you're gonna have your response. And then if you can get the antibiotic that you need, then you can use imipenem. I'm gonna write it here because the name is imipenem or vancomycin. They work really, really well in complicated cases. Otherwise, I will just use amikacin.
Okay. Like common antibiotics that we can use in horses, mainly, I think penicillins will work better, no?
Yeah,
Penicillins,
yeah.
penicillin. Okay.
Penicillins, yeah, they work well. They work well, but I would recommend penicillins to use in a regional infusion just because the potential of the medicine is not as good when you have it in a short time of period. So what happened with penicillins is that if you use a exotic penicillins that will be every 6 hours, you're getting concentration effect, right? So if you do one regional inperfusion, it's not going to work as well.
Then there is another question.
Okay.
For regarding the castration, where which one will you prefer, like ligating the spermatic cord and the blood vessels, or going to the emasculator, use of an emasculator? And there is another one, Henderson's equipment is there by using the drilling machine.
Okay.
I have seen some.
I will prefer the emasculator for sure. Delegation has a lot of complications for in my opinion. You have a lot of opportunities for the suture to rupture, for the start bleeding. So even if you are starting to do this, just do both. Use the ligation, but use the emasculator as well. So you have like double sure that you can sleep better that night, right? That the horse is not gonna bleed out. But I like the drill technique. If you go to my Instagram web, I have a video of that. But you need to have experience of that, because if you do it too fast or too slow, the horse is gonna bleed. And it's gonna be a pain in the butt to suture because it's hard to find the vessel. It's really hard to find the vessel. So yes, you can do it. The position has to be very, very perpendicular when you put the drill. And then the pressure, you can go like fast and then slow. You have to keep the same rhythm all the time until the testicle come out completely. Okay. Obviously, after you use the drill, always put gauzes in and make sure there is not an active bleeding in there. But it works really well. It's really fast. It's safe. Mostly because it's really fast. It's faster than other techniques. You really don't need to wait 15 minutes until the emasculator works. So it is really good. And then the other technique that I knew from Dr. Tracy Turner in Costa Rica when we went to the Equitarian Initiative workshop is this technique that is called the equi twister. I don't know if you have heard of that. Before last year, I have never heard of it before, and it's really easy. I loved it. So what happens is it has like this shape, and then you literally tangle all the testicle in, and you start like rolling, like doing this motion. Okay, so if you don't feel like really confident, just do a suture first, a ligation first, and then you can use this technique. It's a really cheap device. I guess they really like invented it. They made it. So you pull it, and then the testicle come out really easy. If you have a horse like older than 5 years, I would recommend that because the testicles are usually really big and you don't have enough space. But in young horses, it works really good.
Thank you, ma'am. One request: can you stop sharing the screen, that presentation?
Sure. I'm sorry.
No.
There you go.
Thank you.
Okay.
Because regarding that, the same question, because in most of the times in the field condition in India, many horse stud farms and the race courses, there they will use usually the emasculators for sure. But in the field cases, usually we use the ligation technique. Mainly we use the catgut suture materials for the ligation and all. And the most common complication I also have seen is the post-operative swelling. For at least a week, there will be a greater swelling, just like testicles, just like the size of the testicles. What is your opinion? And most of the time they use the steroids to control the swelling. What is your opinion on
Okay.
that?
So my opinion will be the following. So if you have a horse that is more than 5 years, for sure I will do, because you have two options. You can do the castration standing, that if you're gonna use the drill, it's gonna be standing in most cases. It's gonna be easier for you to position the musculator, and you can do it under totally general anesthesia on the floor. If I have a horse older than 5 years, I will do it on the floor. It will be easier because what I'm saying, the testicles are bigger, all the vessels are bigger, and you have more chance of complications. If I have a younger horse, I will do it standing under. What I usually use is dexmedetomidine and butorphanol for sedation. It works better than the xylazine, and it gives them analgesic effect. So I will do that, and then it's just that I never use ligation. I'm sorry, I never use it. I don't feel comfortable. I don't feel comfortable, and I don't sleep well if I do just ligation. So if I see that the vessels are really big, what I do is do both. I do the suture, and then use the musculator just to be really, really sure that we're not getting that swelling that you're talking about. So for the swelling, I always recommend the trainers to do cold hosing, cold water in the area without pulling in the incision, right? But using like cryotherapy, cold water, and then the exercise. Walk the horse. Don't keep the horse in the stall. Just walking really slow for 15, 20 minutes around, so the horse doesn't keep all the fluids inside. Okay, that works with the swelling and the cold hosing.
Thank you. Thank you. There is another question. There are a
Okay,
lot of questions.
I have time for two more questions because I have another meeting next.
Fine. Regarding the treatment of a strangles, have you ever faced the strangles cases in Equine? Yeah.
Okay.
But is there any your procedures of treatment?
Okay, so for strangles, I remember that I had an epidemic of strangles for 2 months, and it sucked. It is a really hard disease to treat, not because the disease itself, but because it gets infection in other horses really fast. So when you finally get one horse better, then the others get sick, and it's really complicated. So mostly you're gonna use penicillins, aminoglycosides, and then you can do flush of the guttural pouch, guided but your scope. So you're gonna put the scope in one nostril, then the little device in the other, and you can flush it with povidone. You can flush it, and then if you have the opportunity in the States, and I know there is a way to prepare it, I don't know exactly how, but you can prepare penicillin in gel. So you keep it in the fridge, and then after you flush the guttural pouch, you can put the penicillin inside the guttural pouch, and it works really, really good. You can do this every 24 hours or every 48, depending on how bad is the horse clinically. And when you leave the jelly, it works like a antibiotic of deposit. So you start like delivering the action slowly, but it's there. So it works really well, the penicillin in gel.
Thank you, ma'am. There are many questions. Let me leave that one. Okay, it's fine. Thank you for the webinar. Thank you for doing this to us, ma'am.
You're welcome. I feel very honored to be with you guys, and I hope it really helped the information that I gave you, so we can all provide a better veterinary services for our horses.
Yes. Thank you. And it was a very nice webinar, and we had a good knowledge from sharing from you. And most of our audience also loved it. And if it is possible, we can get some material so that I can distribute also for the interested peoples in the coming days.
Okay. Yeah, that works. That works. If you have any more questions, you can text me or email me, and I will reply as soon as I can. Okay.
Sure, ma'am. I will definitely ask you. Thank you.
Okay. And if you can send me the recording of this presentation, I will really appreciate it.
I will send the all edited YouTube link to you, ma'am.
Awesome. Cool. Thank you so much. Have a great day.
Have a great day to you, ma'am. Safe, happy.
Bye.
Thank you.